Hello, my name is Brian Clark. I'm the Chief of Police here in Norton, and today we want to talk about some opioid addiction and resources. Today I'm joined by paramedic and Director of Emergency Services for the Fire Department, Michael Wilson, and Dr. Patel, who is the Director and Chief of Emergency Department at Sturdy Memorial Hospital. So everybody seems to know somebody that has suffered from an opioid addiction, whether it's a friend, family, co-worker. Some people might even know people that have overdosed or even died. Last week we had a vigil here in Norton that where we read the names of approximately 100 people who are friends and family of who put forward for those names to be read. Last year we came and did a segment about opioid addiction, and we talked about NOPE, and the Norton Opioid Prevention and Education Collaborative, which is a group of community leaders that are put together to discuss planning, prevention, awareness, and that's what we want to get through today. So when we have an opioid addiction and we get called for an overdose, we have a co-response with the police department and the fire department. And on the police end, following that, we have our problem-oriented policing unit that does some follow-ups. But today we kind of wanted to get into what the fire department and the other emergency services that are provided do. So, Paramedic Wilson, on your end of things, when we have a co-response and we go and there's a victim, how does the fire department handle that?
Well, you know, as you're aware, our dispatch center is a central dispatch, so we get dispatched together, usually with police and fire. When we get there, first thing we do is scene safety. So we wait for the scene to get cleared and wait for the police to tell us that the scene is safe to go in there. They usually have an assessment at that time and will tell us basically, you know, what we have as far as a patient, the age, and the condition of the patient. We'll go in at that point. Usually we send an ambulance. Sometimes there'll be an engine response with that, or the officer will respond in the car along with us. When we get to the scene, we're going to assess the patient. And in most cases, if we're dealing with an overdose, the issue usually is a respiratory issue, and they're either not breathing or not breathing well enough. So we start with that basically and breathe for them, try to ascertain, you know, if they've taken anything, if it's an opiate or other type of either a narcotic or any other type of overdose. And if we do ascertain that it's a narcotic overdose, we will administer Narcan. We have a couple different ways we can administer it. We can give it nasally, which is something that's, you know, fairly new. First responders can do that. Bystanders can do that if they have family members that, you know, have past addiction or past overdoses. Sometimes we'll start an IV, we'll give it IV. In most cases, we'll give it nasally first, and then after that, we'll give it IV. And probably I'd say, you know, 90–95% of the time, the person will actually wake up after a period of time from giving the Narcan, because it does block the response of the opiates. And at that point, we'll get them to the ambulance and transport them to the hospital. The police will usually talk to the family and let them know what services are available and, you know, things that they can do to help their, you know, their family member. And a lot of times, as you know, they'll go up to the hospital along with us or shortly after us and give them all the information they need.
So from Norton, I was looking at some statistics earlier today, and in the last couple of years, we've basically had about 100 overdoses. 20 of those have been fatalities, so that's, you know, a fifth of the overdoses that we're responding to, and that's just what that we know about are end in a fatality. But when you bring them up to the Sturdy Hospital, they then end up in the emergency room. And what do you do for treatment options there?
So the paramedics have already administered Narcan if they need it. So a lot of what we're doing initially is just monitoring them. Depending on what substance they took, sometimes they can have a recurrence of difficulty breathing or getting sleepy again from the medication, and we may need to give them more Narcan. Sometimes they have to be admitted to the hospital for closer monitoring if they continue to be sleepy from the medication. Also, sometimes depending on how much they overdose or what they overdose on, they can get a lot of medical complications from it. So they can get fluid in their lungs, their muscles can start breaking down, they can drop their blood pressure, and so they may need to be admitted to the hospital to be monitored and kind of stabilized through that until they're medically stable. Once they're medically stable, if they remain in the emergency department, then we do the best we can to try to offer them resources, try to help with their addiction. So we can offer them an evaluation by our licensed clinical social workers that are in the emergency department, and they can speak with them and provide them different options for detox, rehab, outpatient resources, things to help get them the treatment that they need, related to the opioids.
So both of you are, regular members of NOPE and come to our regular meetings. And we had a discussion, it was kind of like an off-the-cuff discussion where one of our officers actually broke an ankle and went to the emergency room, and he didn't get, any type of medication. So there's quite a few different treatment options out there. Can you maybe just talk about what other options there might be?
So, historically we've always talked a lot about using like pain pills, to treat medication. A lot of that was in the form of narcotics like oxycodone, hydrocodone. Now we're looking at, different options and different therapies for treatment. So for someone who's injured an ankle, for example, really the best treatment for that pain is elevating the ankle, ice to the ankle. Anti-inflammatories like ibuprofen, work really well. And we tend to try to recommend those medications primarily, be it before going straight to opioids to treat that. We also at the hospital have developed what we call non-opioid treatment protocols for specific painful conditions. So for example, if you came in with a kidney stone, we would start with using a medication called Toradol, which is another anti-inflammatory medication. We can use lidocaine, which is an anesthetic. You can give it IV. That helps with pain as well, but doesn't have a narcotic in it. There's a disorder called cyclic vomiting that patients present with sort of recurrent vomiting and have a lot of abdominal pain. And historically, we used to use narcotics to treat that, and now we've kind of shied away from that, and we try to use other medications that don't have narcotics in it. And we have a whole protocol that the providers can go through to try to give them these medications before they go to opioids. One of the other things we're looking at now, sort of for the future, is getting our providers trained on what we call regional nerve blocks. So injecting an anesthetic into an area to try to numb the pain rather than just going straight to pain medication. So, for example, if an elderly person comes in after a fall and has a hip fracture, rather than giving them, morphine or fentanyl for the pain, which would make them drowsy, nauseous, have a lot of side effects, we could inject anesthetic into the leg and just numb the leg so they won't have pain from the fracture until the fracture gets fixed. And so that's something that we're looking at doing as well. So
you mentioned at, I believe, the last NOPE meeting that it's actually okay if your body is in pain because it's telling you that something's wrong.
Right.
And, so you're aware of it. So it might, if you go to an emergency room, you may not be prescribed anything depending on what exactly happens.
Yeah, it depends on the situation. I think it's a conversation to have, and it's not that we don't want to treat pain, but I think a lot of it is education on the expectation of what pain is, and the expectation that we're not going to necessarily make your pain go away completely, and nor should that be a goal. The idea is to get your pain under control to the best that you can, but also understanding that you probably have to tolerate some level of pain because you have an injury or a painful condition, and it's kind of your body's way of telling you that something's going on. But we're trying other alternatives to try to manage pain, that don't involve the use of opioids, which, historically also have not necessarily been great therapies for pain. They may dull the pain a little bit, but then they have all the negative consequences that come along with it.
So you also mentioned the pain chart, that if, if somebody has pain of 9, that you try to get them lower. So it's not like you're trying to alleviate the pain altogether.
Yeah, so the pain scale is it's a scoring system that we use to get a sense of where people are in terms of the severity of the pain, but it's a relative scale. So, for example, my pain level of 9 could be your pain level of 2. It all depends on the person. And the idea is not to get your pain level to 0, but to say, can we improve your pain? So maybe get my 9 to a 5 and get your 2 to a 1. And so you're looking at gradations of scale as opposed to saying the goal is to 0, because that a lot of times you're just not going to accomplish that goal.
So last August, I believe, we had about 7 overdoses in a 2 to 2.5 day period, and certainly that's something that from the fire department and the police department, those type of simultaneous calls has an effect on the staff and the resources that are available. How did the fire department deal with simultaneous calls and things like that?
Well, as you know, a lot of these simultaneous calls are people that have utilized our services in the past, and that's unfortunately the vicious cycle of addiction. We may have a person and then have them again a day later, a week later, a month later, and sometimes multiple times within that time frame. So, it always, just like anything, we're a small department. It definitely taxes our resources if we have to go to a call with other calls going on. We do have a callback system that we will call other people in if we do get shorthanded. But just like anything, the calls always seem to come, when there's other people out on other calls, so there's always an issue as far as that. And the other thing I want to bring up on top of what Dr. Patel was saying, in the last year we've kind of changed our thinking in the ambulances too. Historically, ambulances have always carried narcotics if they're at the paramedic level to administer to patients. We're with patients for a short period of time, so it's usually just something quick to get them comfortable until we get them to the hospital. But in the last year, we've actually now are offering alternatives that are non-narcotic stuff, such as Toradol, like Dr. Patel said. We're offering to patients ibuprofen, Tylenol. There's an IV Tylenol form that we can offer. So we're trying to help out with that situation too. And in certain cases, we'll offer the patients a non-narcotic approach and do the same thing that they're doing at the hospital. As far as that goes, if the condition warrants. We still do have narcotics. If someone, is in severe pain or has a severe injury, we still have that we can administer. But we do have alternatives now, especially people who are in the process of going through getting sober. A lot of them don't want any of the pain medication because they want to have an alternative. And up to about, like I said, about a year ago, we had no other alternative. It was either a narcotic or nothing else. So that's an improvement on what we can provide in the ambulance also.
So we had talked a little bit about some legislation that was being suggested. In particular, there is a legislation that if a patient goes to the hospital, that the hospital could hold them for up to 72 hours. But we had an offline conversation about how that is going to hamper, say, the emergency room, and you had some thoughts about that.
Yeah. So I mean, I think the fact that this attempts to address the opioid epidemic is going through legislation is fantastic. I think trying to, hit it from every different avenue, to try to help these patients that have opioid addiction is great. I think the problem, though, is, with something like the 72-hour hold, the issue is not so much keeping them for that time period, it's what to do with them after that. The resources are lacking in terms of bed availability, treatment facilities, other options for them to go to help with that. So, if they're being held in the ER for 72 hours, we're not really doing very much for them other than having them wait until a bed becomes available. And so, if you're going to enact that process, you need to have enough availability on the back end to make sure that they have places to go to, so that we're actually offering patients, a useful option for addressing their addiction. Because being in the emergency department, beyond the medical part of it, is not really giving them the therapy they need, the medical treatment they need for their opioid addiction. It's just kind of a holding area until they get to the facility that they need to. And again, it also, the other part of that is it brings along the challenges of how do you keep somebody in the emergency department for 72 hours. Many of these patients, once they're awake and back to baseline, they don't want to stay there, any more than they have to, and they're looking to get out and, get out of the emergency department. And so then the strain on the staff and resources to, essentially force these people to stay in the emergency department involuntarily becomes very challenging as well.
I think last year when we did a review of what we've done for, working as a working group with NOPE, and we discussed with Congressman Kennedy's office that, one area that they need is more treatment and more beds. And that's, I think, a work in progress, probably. From NOPE's perspective, we still work on awareness and prevention. That's what part of us are doing here today. We are looking to collaborate with the schools in the next month or so to bring some speakers to school. We also started last week. We have an intern from Wheaton College who's going to help us get some prevention programs together by checking out some commonalities that have occurred through our overdoses. So we keep, as a community and as a town that people live in, and this is happening frequently, we continue to work on this project. Both of you must, especially Dr. Patel, you see it as a regional issue as well, because multiple towns go to Sturdy. And even from mutual aid perspective, you're assisting with other towns on mutual aid as well. So, what are you seeing at Sturdy as far as how many monthly, people are coming in?
Yeah, I mean, we see about probably 20 to 25 overdoses a month, amongst the 7 to 8 communities, that we serve. So it's a fair amount. I mean, that's almost 250 overdoses a year on average. Well. And, we offer all of them evaluations for detox and rehab and, not all of them accept that offer or option. We do also provide anybody that comes in after an opioid overdose, we provide them or their family members Narcan to take home with, because family members can administer Narcan nasally just as well as a first responder can. And having that option at home can often save their life if the family member can administer the Narcan even before EMS gets there. So we do discharge them with the medication in hand. It's not a prescription, but we give them the actual medication to take home with them to try to help prevent any deaths related to the overdoses.
Oh, good.
So.
Good. Is there anything else that you'd like the audience that are watching at home know about?
Yeah, I mean, I think it's a good idea to have the Narcan available, but the family members also have to understand that that's just one piece, of the big puzzle, and just don't want anybody to get like a sense of well-being once they administer it. They should always still call 911 regardless of the situation, even if the person wakes up and is acting normal, because it may not last very long and they can still have side effects later on. They should still call for emergency services and police department, just so we can go and evaluate. Doesn't mean if we go to somebody's house we have to bring somebody to the hospital, but a person should be evaluated rather than just thinking that everything's good from that point. They should still call 911 in that situation.
Okay. Well, thank you for joining me today. From a resource point of view, we have two detectives that work on follow-ups, Detective Winters and Precourt. They certainly are available for assistance if anybody would like to reach out to them. And also from a bigger regional aspect, we've joined with the Greater Attleboro Recovery Network. And the last Wednesday of the month over at the Murray Unitarian Church on North Main Street in Attleboro, there's the Garn Meets, and it's a drop-in center where there's a host of different resources available for people to pick up information about. So if anybody has any questions or concerns that they'd like some information about, certainly feel free to reach out. And I thank you for watching.